it's a true honor for me to be here today, and really a great thanks go out from myself and our group to all of you and to the Organization of Pancreas Cancer Canada, really trying to give this disease a voice. The patients need a voice. The clinicians are trying to give the patients a voice. And so really the work done by this organization and by all of you really inspires us as we go to the operating room every week or we go to clinic every week. And obviously all of you inspire us as well. And so I'm going to follow my mentor, Steve, and tell you a little bit about sort of what's the coming forward in pancreas cancer surgery. Because we're not satisfied with the status quo. We are pushing the boundaries, we are fighting, and we're fighting to make the operations not only more easy to get through and less invasive, but also offering surgery to more people. So I talked to Steve and the group. We didn't want to just focus on the minimally invasive part, but also tell you a little bit about how we're pushing the boundaries in all aspects of pancreas cancer surgery and how you all have been so supportive for us in that endeavor. So as you know, the people in this room are testaments, and we strongly believe that really this cure is the goal. And as we know, the journey to cure often goes through surgery, or almost always has to go through surgery. So we have to accept surgery as part of that cancer journey. And really, how can we make it an important part, but also make sure it's evolving, not only being more patient-friendly, but also making sure we can bring as many people under that curative tent as possible. So we know that surgery is important. We know that we know that it really offers us our best chance of cure. Obviously, we know that these numbers are not where we want them to be, but we are all, you are all striving, we are all striving every day to push these curves higher and higher. It's important to relieve some of the symptoms, and obviously the overall goal is cure. But really, probably surgery is only part of the equation in terms of the journey to cure. And we know that we need to combine things with surgery to make it more and more effective. And that, of course, as you know, for many of them is chemotherapy. And we know that chemotherapy is effective, and as many of you know, there's been actually fairly significant advances over the last 3 or 4 years in terms of chemotherapy for pancreas cancer. And really, we're hoping to use these advances as a springboard to push forward in the next era of surgery. And so you can see here the very effective improvement in survival, and really we know that combining surgery and chemotherapy at the same time is really going to push us towards offering cure to the most number of people. So what's happened in the last sort of 10 years? Well, we've made the operation safer. And we know that the rates of complications have been relatively stable. The proportion of patients surviving the operation has gone up significantly. And it's important to say, well, with the complications didn't change, but what we actually did over this period of time is we were able to operate on people who were not as healthy as they would have been beforehand. 10, 15 years ago, you had to be in perfect health to get a Whipple procedure, because we really couldn't get older patients through this surgery. And now operating on people in their 80s is just much more common. And again, offering those people in their 80s the chance of cure, because we all know that they have very healthy and vibrant lives ahead of them if we're able to get them to that goal of cure. And so we've been able to do that by looking at improving all of our aspects of the surgery journey, making sure that patients are as healthy as possible, that it's as least traumatic as possible, and in doing that, being able to, again, expand the tent of cure by offering surgery to more people. So what's on the horizon? Really, I think we're looking to offer surgery to more people, so people that would have been declined in the past. So as I said, we're certainly able to operate on people with health problems. We're able to operate on older people, so we're expanding that tent. And are there other people that we can offer surgery to and offer that goal of cure that in the past wouldn't have been eligible for that type of surgery? And then the second thing is, can we make, as Libby said, surgery less invasive? Can we make it easier to get through? Can we make it less painful? Can we get patients through their surgery safer and get them back home to their families much sooner so they can get back to that healing process and again on with their journey? So again, looking at not just safer surgery, but really faster recovery. And this is about as graphic as any of the slides I will get, so I will that'll be the caution. But one of the things that has allowed us to expand that tent of surgery is just our ability to take some of the blood vessels near the pancreas apart and put them back together again. Those would have been sort of deal breakers in the past. If your tumor was wrapped around these blood vessels, that would have you would never have gotten to the operating room. And now, because we have learned a lot from our transplant colleagues, and also just through practice and expanding our training, learned how to sort of take the pancreas out and take some of these blood vessels apart and put them back together again. And that means we're just able to tackle much more aggressive cancers. And we're able to, and because we've gaining experience, we're able to look after these very complex patients after their operations. So this is actually where the pancreas used to be. This is the superior mesenteric vein, or this vein, and the portal vein. This runs right kind of through the head of the pancreas. And here, vein's been taken apart and put back together again. These are the blood vessels coming back from the intestine up towards the pancreas. And here's the artery that supplies all of the blood supply to your intestine. And we've been able to take that apart, and put it back together again. Again, things that just wouldn't have been possible, and patients with those kind of tumors just would never have gotten to the operating room, because we would have said we would never have been able to take that tumor out. And so again, looking at these, we're able to use various things to put blood vessels back together again. So we're really sort of trying to expand the borders of surgery, and again, offer surgery to patients that would never have gotten to the operating room. And so these are the kind of tumors that we're looking at. Again, in the past, we really were only operating on a very select group of individuals that had very small tumors. But here you can see, if this is the head of the pancreas here, cut sort of like sort of down the body. So you're looking at it face on, and you can see that the tumor is starting to wrap around these blood vessels. And these are the kind of tumors that we're able to approach today with these reconstructive techniques. So then the question we start to ask ourselves is, well, we can do these great surgeries, but how can we make it most effective? Because all of these advances do come with a bit of increased risk, and we do need to take into account the very important things. We need to consider the tumor itself. We need to look at the biology of the cancer, in other words, how this cancer is behaving, because not every pancreas cancer is the same. They all have their own behavior, their own genetic code, and some are aggressive and some are less aggressive. And so we need to take that sort of behavior into account when we're planning these operations. And so we need to sort of look at it, when we look at expanding the boundaries, can we do it in a reasonable way that makes sense for people? Because we know if we can take patients that wouldn't have been operated on in the past and operate on them now, we can improve their survival. We can realistically offer these patients cure. So this is a study that we've done, and the details really aren't as important as to say that these were a group of people that really, so this is a 44 group of patients in our hospital that wouldn't have had surgery based on the extent of their tumor. And what we did is we gave them some chemotherapy and we gave them some radiation. And what that allowed us to do is to really push the boundaries in people that had a tumor that responded or stabilized on chemotherapy, and allowed the radiation to shrink the tumor to allow us to get all of the tumor out and not leave any tumor behind. And while not every patient's going to get through chemotherapy and radiation, some patients unfortunately will have very aggressive tumors that will grow on chemotherapy. We are able to get the vast majority of patients through to their operations. Now we say, well, we lost some people here along the way because we gave them chemotherapy and their tumors grew and progressed. But unfortunately, as we know, too often these patients probably may not have benefited from the operation. We would have put them through a horrible operation, very extensive recovery, really with very little benefit. So using the chemotherapy to choose patients wisely and pushing the envelope. And when we did that, we were able to see that it did make sense to push the envelope, that these were the patients that we were able to get through the chemotherapy and the radiation. And when we looked at the patients that were, again, in this expanded criteria compared to our common criteria, we were able to bring those patients who wouldn't have been offered surgery in the past, offer them the same kind of cure rate as patients that had traditionally removable tumors. And so this, again, just reinforces that point in that we can use the chemotherapy to sort of separate the very bad tumors to the somewhat good tumors and really start to offer patients who wouldn't have had a chance of cure 5 years ago, the chance of cure, because we're able to sort of push the envelope, but in a sensible sort of way. And so, all right. So next, as Libby said, we wanted to not only push the envelope in terms of expanding the borders of surgery, but also try and make the surgery less invasive. And as everybody knows, that there's been a push for less invasive surgery in all sorts of domains. And pancreas cancer is probably one of the last areas where minimally invasive surgery has really taken a foothold. And there are many factors for that. It's a little bit around the complexity of the disease. It's a little bit around the complexity of the operation. And to some extent, it's a little bit of the limitation of the tools that we have in the operating room to perform these operations laparoscopically or through small incisions. So we need obviously significant investments in our operating room, and certainly Pancreas Cancer Canada has been extremely generous in helping us in this regard. So we not just need the regular operating room and all the regular machines, but we need the screens and the telescopes and the lighting that all help us do these operations, and it's a significant financial investment. And you need the team. So this is me in the middle. This is Alice Way and Caroline Moulton. So the three of us are all work with Steve at UHN, and the three of us have really sort of committed to this program of trying to push the envelope of pancreas cancer surgery through small incisions. And so really this is the goal, and these are real pancreas cancer patients. And just to compare, as Libby said, either the incision through the left side, because these patients had tumors in the tail of the pancreas. The white line is the operation they would have had, and you can see the small incisions that they had here. And most patients seem to think that we can only remove small tumors through these very small incisions, and through an incision like this, but we can actually remove quite large tumors through these small incisions. And you can see here we've used an incision that you may recognize if anyone's had a cesarean section. We use that same incision because it's one that's very easy for patients to get over. It's very easy for them to recover from. They don't have a lot of pain. They're able to get up walking much, much sooner than they are through other incisions. And again, if you can remove a baby through this incision, we can get any size of tumor out of here. But this is really our goal, to try and offer these kind of incisions to people where it's possible, but not compromise the operation. So again, does this kind of make sense? We don't want to sacrifice any aspect of the effectiveness of surgery. We certainly don't want to risk our chances of cure by changing the technique. And so we know that through doing hundreds of these operations, certainly it does take a little bit longer to do it through the small incisions. But interestingly enough, the way in which the operation is done by blowing air into the abdomen actually decreases the blood loss in the operations. We know that patients can get home much faster, and we can do it with about the same complication rate. In other words, we're not increasing our complication rate, and we're not impairing the effectiveness of the operation in doing this. And so this is actually our own data here at UHN. And so you can see here, compared to an open operation, patients are able to get home at an average of 2 days faster. Now that seems like a relatively minor thing, but if you were to watch these patients, and that means they have less pain after the operation, they're able to get up and walk around a lot sooner, they're able to start eating a lot sooner. And while those 2 days may seem relatively minor, that improved recovery extends right throughout their journey. In other words, as they get home, they really do start to recover much, much faster. And so when we see them a month afterwards, they're not struggling to the same extent that patients who may have had larger incisions do. And obviously, the incision complications are a lot less because they have just simply smaller incisions. And our hospital doesn't mind this. This is actually looks at the cost of the operation. So obviously we need to, as Canadians, be financially responsible. And we see that these operations, because patients are able to get out of hospital quicker, they actually use fewer pills and narcotics during their time in hospital. It's actually, we can get them out of hospital faster, and it costs our hospitals less money. So in terms of a healthcare system, this is probably a way in which not only we should be pushing in terms of investing in the technology, but these are investments that will pay off in the long run because we'll save our health system more. So so then when we start to look at the Whipple procedures, as we know, this is, as Libby said, this is a 6-hour operation, would be a relatively average Whipple. They can certainly go on much longer. Can we do those kind of complex operations laparoscopically or through small incisions? And as we can see here from this series, we can really start to do it with the very same complication rates. And what we found, what people have found in this series is that actually because people recover much quicker, they're able to get on to chemotherapy much sooner, and more of the patients are able to get to chemotherapy because they didn't have problems with their incision or with infections or in their wound. And so really, in terms of getting the whole journey together, getting patients to chemotherapy much, much sooner. And can we do it all without compromising the effectiveness of the operation? Well, this is actually a very large North American series that we contributed to, and the laparoscopic patients actually in this series did slightly better than patients who had an open operation. And whether that's because there's something oncologic about a large incision or because these patients were able to get to chemotherapy sooner, we don't know. I would suspect that it's probably going to be, from a cancer perspective, about the same. I don't think it'll be a better cancer operation, but I think it will be one that's much easier for patients to recover from. And so this is sort of the question we start to ask ourselves is, how do we start to push the boundaries of laparoscopic surgery? How can we make sure as the operation gets more complex that we're able to offer the same operation through small incisions as we could do with big incisions? And there are lots of sort of technical challenges to these laparoscopic operations that we need to overcome. We're working from rather than working with our hands, in a sort of an open environment where we can touch things and feel things. We're really operating by looking at television screens and by moving instruments within the patient that are kind of resemble chopsticks. So it's a little bit like trying to eat with chopsticks instead of eating with your hands. And so how can we do this? Well, we've obviously had lots of innovation in terms of the tools that we use, but also in the way in which we see things in the operating room. Because one of the real challenges of the operating room in laparoscopic surgery is that we're operating in 2 dimensions by looking at a TV screen. And if you were to think about that, if you wanted to sort of try and bring an example together, it would be like trying to bring your 2 fingers together and point them one at each other, but not by looking at them directly, but by looking at them maybe through the screen of your iPad. And what you've done there is taken away your depth perception. So your ability to perceive how far away things are, how deep they are, how big they are, how small they are, and you've lost your ability to feel and touch things and see what they feel like and what feels like cancer and what doesn't feel like cancer. So these are some of the things that we've tried to overcome, and we need to continue to overcome if we're going to continue to push the boundary in these operations. And one of the things that we've brought into our operating room, and we are the first in Canada to do so, was to bring in 3-dimensional imaging for the operating room. Now, the obvious question is, well, I've had a 3-dimensional television, a 3D television in my living room for the last 3 years or 5 years, and my kids can watch, Harry Potter in 3 dimensions. Why can't I do operations in 3 dimensions? And it really was just a matter of waiting for the technology to develop to an extent that it was usable in the operating room, that the glasses could be worn, that the instruments had a high enough fidelity that we could actually do an operation while watching it rather than watching Harry Potter. And so this is sort of our operating room now. And so these are sort of the type of setup that we would have, because we're operating through screens and using instruments on the outside of the body. And this is our team here. And this is kind of what the technology we were waiting for is, because in order to see in 3 dimensions, you need 2 eyes. And what we do is our eyes are obviously slightly separated and the difference between what we see in our right eye and what we see in our left eye helps our brain recreate a 3-dimensional image. Animals that don't have 3-dimensional imaging, for instance, pigeons, aren't able to see in 3 dimensions, so they move their head back and forth when they walk in order to see how far away that piece of bread is. So what we've been able to do is, for the longest time, is just being able to look through one eye, which is the scope of the instrument. But now we've got the development where now we have 2 scopes on the end of an instrument that's about this from here to here is about 7 millimeters. And this has not only two high definition cameras within it, but two light sources as well. So we're actually able to see the offset that we need to do. So as you can see, we've created the two eyes again that we need to see in 3 dimensions with. And what happens to that picture is that those two pictures come in, and they're basically two slightly offset pictures of something we're operating on, and it brings those two images together in that appropriate amount of offset. And then really just using the same glasses that you get at the Cineplex or at the TIFF Lightbox when you're seeing a 3-dimensional movie, we're able to recombine that in our brain because, again, you only see one image through each of our eye because of a change in the way in which the glasses see. So when we do that, we're actually able to recreate a 3-dimensional image in your brain, and it's like watching a 3D movie instead of a 2D movie. And so again, this is our group here, and we've all got the glasses on. And again, there's just what we found is that it's a great technology. It allows us to be much more precise in the operating room. It allows us to do much longer operations while we're working laparoscopically, because there's a strain that you experience in your eyes and your brain when you're constantly working in 2 dimensions but trying to recreate a 3-dimensional structure. So this allows us, because we're working in 3D, to work much longer and do much more complex things, because our brain isn't expending that sort of amount of energy trying to recreate 2-dimensional and 3-dimensional things. And again, so this is just our group. You can see here, these are the kind of instruments that we use on the outside of the abdomen here. In order to create space in the abdomen, we pump air into the abdomen so it becomes a little bit bloated, but gives us the space to operate. And again, we can look through the glasses and see the 3-dimensional television screens. And has that really allowed us to make progress? Well, I think it has, because these are just some very sort of a little bit more complex tasks that we would do. For instance, suturing. So you can imagine trying to tie a piece of string with chopsticks. It's a little bit of a difficult procedure. It's one which kind of is one of the things that holds us back. And we notice that we're able to do really things a little bit more quickly and a little bit more precisely when we can work in 3 dimensions. Because again, we've established the 3-dimensional vision that we see, and we can work in a much more precise way in that environment. So now what's next? Because of course we're never happy with the status quo, and this is kind of, I wouldn't have been able to give this part of the talk last year, because over the last year we've actually been able to introduce robotic pancreas surgery at UHN. And just to give you an idea of what robotic surgery means, I know you've probably seen a lot about it in the press. This is the robot here. It's called the Da Vinci. And this robot has a camera, because we need to be able to see through these small incisions, and it has 3 arms that operate inside the patient. And the surgeon does not scrub anymore. The surgeon actually doesn't touch the patient, but operates through this console over here, which can be, in our operating room, it's about 7 feet away from the patient, but they've done operations where this surgeon can be on the opposite side of the world, because you can control this robot really through cables and fiber optic cables that run between these 2 instruments. Now, why is that better than laparoscopic surgery? So why is this really, we think, one of the next frontiers? Well, the robot, so to speak, can do a number of things. Rest assured, it can't do the operation by itself, so my job is still safe for a little while. But what it can do is it can take very precise movements of the surgeon's hands and replicate them inside the body. So I remember I said before, operating laparoscopically is like operating with chopsticks, and maybe some of you are quite skilled with chopsticks. Not all of us are, and it can be, it can take a bit of time to pick up a piece of sushi with your chopsticks. Well, this is taking those chopsticks and turning them into small fingers or hands. And this is our robot, and you can see here, again, there's 3 arms and a camera, and these are the way in which the arms set themselves up around the patient. and we can operate inside the abdomen again from a place over here. And I, again, sort of wanted to stress that this could potentially be a really great frontier for us, because this is the way we've been operating laparoscopically with the chopsticks. You can see here we can grab things, we can turn things, but really we're operating with straight instruments that don't bend and they don't flex. So really we're limited by, again, just operating with chopsticks. Well, here's what the robot can do. And so this is the arm of the robot, and this is probably about a centimeter in size from this end to this end. And these arms have wrists, and they move around. And they can grab things, they can push things aside, we can suture with them, and really all the robot is doing is taking the motions of the surgeon's hands in that console and replicating them inside the body. So if you bend your own wrist in the console, the robotic arms bend inside the patient in the same degree of rotation, this exact precision of the movement, and even a little bit better, because there's a little bit of the program in the robot that eliminates tremor, it eliminates imprecise movements, and so they've really done a fantastic job designing these instruments. So I can't, I didn't want to show an operation per se, that's not everybody's cup of tea, but this is just to sort of give you an example of what these robotic arms can do. And this is a robot basically making an origami swan. And this is not the robot doing it itself. This is a surgeon moving his arms or her arms inside the console and moving these arms back and forth. And you can see those arms from here to here is about a centimeter. So this piece of paper might be about 2 centimeters across. And then you can see that we can really do quite precise and quite fine movements that just aren't possible through laparoscopic surgery. And so this is just the kind of precision we can get. And again, all through small incisions. You can see the arms here that further back. Here, you actually can't see it as well in these videos, but those are about 5 millimeters in diameter. So that means we need a 5 millimeter, a half centimeter incision to get those into a patient. So that's a 5 millimeter incision. So we can do more than just fold origami with this, but just to show you that the precision involved. This is the skin of a grape. And here, what this robot is going to do is suture the skin of this grape back onto the grape. And so you can imagine how fragile the skin of a grape is. And it just shows you that the robot, if we give it precise movements and very refined movements in the console, the robot can replicate that. So again, we think some of those tissues that we operate on and those walls of those blood vessels really often have the same kind of structure, the skin of a grape. Here's the kind of promise that we could do, the kind of things we could do if we can use the robot in this way. And again, so it's just going to slowly suture this. You can see we can tie knots, we can suture all through the arms of the robot. Now, at UHN, we're very, very lucky. We have this robot. We're one of only a couple hospitals in Toronto that has them. There are only about a dozen across Canada because it's a definite commitment in terms of training, but it's also been a strong commitment from our foundation as well as a lot of our partners to really to allow us to do this type of surgery, because unfortunately the government has not seen the investment of this kind of thing, and so they don't reimburse the hospital for the robot or to be able to use the robot. But our foundations and our donors and our generous patients have really come to the fore and helped us with this. And so with that, really, it means that we're extremely grateful to the support that Pancreas Cancer Canada and all of the people involved in the organization have done for our group. This is how some of these investments are paying off. And again, I can't say it enough how grateful and honored we are to partner with you in these kind of things. Thank you so much for your time. I really appreciate it.